Thank you very much. Okay. So, did you finish with your slide, Dr. Ricardo? Everything is okay?
I hope yes.
Okay, so now for inflammatory breast carcinoma.
Very good. Thank you so much, and thank you for the introduction. I'm very happy to present today the inflammatory breast cancer, a very intriguing title, New Insight from an Old Disease. This is the description where we are going to discuss these 20 minutes, some historical description, pathological characteristics, the epidemiology, the systemic treatment, novel treatments, and finally the conclusions. So it's very important to mention that this is not a new disease. This was described approximately 200 years ago by Sir Charles Bell, and this was a pure clinical description with the purple color of the skin and associated with the shooting pains. That was the most important descriptions in the past. But we need to keep in mind a couple of things. First of all, the diagnosis of this inflammatory breast cancer is a rapid progressive disease. The expert of a panel of experts create a group of points, and we need erythema, approximately 2/3 of the breast, with PD orange, induration, tenderness, and dermal lymphatic invasion. But this is the last part is not the hallmark. And the prognosis, we need to keep in mind that even that we have approximately 48,000 deaths for breast cancer in the United States, approximately 10 to 15% correspond to the inflammatory breast cancer. Up to 30% of these patients has metastatic disease at the time of the diagnosis, which is in the United States is very high, usually is between 3 to 4%. And these patients with inflammatory breast cancer has the worst survival compared with non-inflammatory breast cancer. It's a 5 years total survival rate of 40%. So this is the common presentation of these tumors. As you see, can be extending completely in the chest wall, bilateral breast, only one breast. This is a disease that comes in many flavors. The diagnosis is it's still clinical, and this is a redness with a hot period and edematous presenting orange skin, and this is basically needs to be in less than 6 months. We know that most of the cancers with the neglected stage 3 breast cancer at the end will mimic one of the inflammatory breast cancer. And based what we discussed before, if the pathology skin confirmation is necessary to declare inflammatory breast cancer, the answer is not. Many times we have a clear clinical definition of IBC. We do several punch skin biopsies and they are negative. In terms of the epidemiology, this is an old series. This is more than a decade, and we can see that the rise of the incidence of IBC has been correlated with the multiple cohorts in multiple decades. We see that the number of locally advanced breast cancer has decreased, but the IBC has been increasing. So this is something important. This is from Sears database. And another characteristic of IBC is the peak of incidence is quite earlier than the rest of non-locally advanced breast cancer compared with the locally advanced. So the mean peak of IBC is in the 50s. And at MD Anderson, when I was there is a tumor registry that has already collected 350 patients. And this is a protocol, it's an epidemiological protocol where all patients are treated with a similar routine lab tests, pictures, demographic assessment. And we found that these 350 patients, the median age were 55, estrogen receptor positive 33%, And this is a date is very characteristic. It's a high proliferative tumors, HER2 positive 44%, and triple negative 1/3 of this patient. But perhaps one is characteristic data is the BMI. 50% of the patients were obese. And this is something very important, especially now we have an epidemic with the obesity and cancer. In terms of the radiological characteristics, this is a historical paper from one of the pioneers of the breast, Dr. Busdar at MD Anderson, and they found that approximately only 50% of the cases in the mammography has a mass. So that is a point that we can learn. This is a tumor. This is a breast cancer without lump, without a patient that no palpate any lump, and also has no mass in the mammography. MRI has been very important, especially for localization of the multi-compartmental lymph node, but perhaps the most important test for us has been the CT PET scan. And the PET scan, because 30% of all of these patients has de novo metastatic disease, and this is a clinical characteristic presentation of the IBC. You can see that many times mimic like a lymphoma the spreading. In terms of the epidemiology, we saw that the breast cancer with the multiple improving the number of drugs, improving the screening, we have improving the survival of these patients. And we use, this is for all comers patients, the database from Sears, and we do this very similar analysis with the inflammatory breast cancer, and we found that there was no improving any survival since the 70s, 80s, 90s to now. However, since in 2006, they opened the IBC Center, exclusive center in Houston for treating this patient. There was a separation of the curves. Majority of these patients are treated under clinical trials, and this perhaps has been a very important improvement of the outcome of these patients. In terms of particular molecular signature, I think previous speakers discussed the Cancer Genome Atlas. This is perhaps the most common slides nowadays, where analyze the DNA of these patients, and with the application of the 4 intrinsic subtype from RNA messenger. So here we learn that, for instance, luminal A has a 35% of the PI3K mutations, triple negatives, has a high level of P53, etc., etc. We tried to do a very similar study with one of our fellows, is Dr. Iwamoto, and we combined 3 different specific signatures for inflammatory breast cancer. And this correspond approximately 180 patients, and unfortunately we couldn't find any single overlap. When we merge all of these signatures, there was no single gene overlap that we have in common. Therefore, we need to have a clear definition of the disease, number one, and number two, start using a different type of tools, like a next gene sequencing, to really understand what's going on with this tumor. So several IBC-specific signature has been reported. IBC might have also a molecular subtype that they like non-IBC. In terms of the treatment of the IBC, is part of the history of the neoadjuvant treatment, because the Instituto Nacional del Tumor and MD Anderson more than approximately 50 years ago started with these programs of the neoadjuvant chemotherapy, and since the introduction of these approximately 25 years were treated with anthracyclines, and since 1997 the inclusion of the taxanes to now. So this is our backbone, is a taxanes with anthracyclines, and treating patients with this combination, we can see that the response rate has been 80 to 90%. But perhaps the most important is the pathologic complete response, something that has been very difficult to evaluate in inflammatory breast cancer. It's a different and it's very tedious work for the pathologist to analyze the sample of patients with the IBC. So in terms of pathological complete response, might be around 10 to 15% of the cases. So this is a summary how we treat these patients with a backbone, taxanes first, followed by anthracyclines. We try to perform a maximum debulking effect, so chemotherapy no less than 6 months, even that the patient has a good response. And for those patients has demonstrate resistance to taxane or anthracyclines, we develop a salvage regimen with a non-cross-resistant treatment with the ixacape and bevacizumab, and we have a total of 18 patients treated in that way. And you can see here a case, a patient that has a refractory to paclitaxel after 8 cycles, take FAC, and then progress again, and with ixacape, bevacizumab, the patient responds very well. So this is a salvage regimen, is a pilot study, but this is the interesting 50% of the patients treated with this combination, patients are candidates again to have a surgery. So the primary systemic therapy followed by mastectomy, followed by chest wall radiation. This is the standard of care for IBC management. Pathological response to neoadjuvant chemotherapy is the most important prognostic factors, and anthracyclines and taxane-based regimens are traditionally used in the IBC. How about the triple modality treatment? That's why that is our goal for majority of our patients. This is a great paper by also the radiation therapies from MD Anderson, and these are 250 patients with non-metastatic breast cancer, inflammatory breast cancer, and you can see the big difference for patients that they complete the triple modality treatment versus the patient that has not complete the 3 treatments for several reasons, toxicity, for lack of access of treatment, and this is a little bit the conclusions for patients, especially for patients with a younger, poor response to neoadjuvant chemotherapy. They recommend to change, instead to have a 54 grade, have a 66 grade total of radiation therapy in the chest wall. And this was also recently correlated by Gilles de Baviera group, also from MD Anderson, in a data from Sears database. And this is a large number of patients. And you can see how important it is to have the triple modality treatment, even in patients that has primary metastatic disease. So for some patients with metastatic disease and IBC, it's important to complete the whole treatment with chemo, radiation, and surgery. In terms of novel clinical trials, has been a very difficult for inflammatory breast cancer to have a models, a xenograft model. There is actually 2 cell lines, that is SUM149 and KPL4, and this was one of the fellows from University of Texas, James Young, and using one of the single EGFR inhibitor, reversible, erlotinib. This you can see how increasing doses of erlotinib decrease the amount of the receptor EGFR, the phosphorylation, but this was dependent of ERK. And perhaps the most important, that this implant of the mammary fat pad has a spontaneous metastasis to the lungs. So this is in mice, and mice that were treated with erlotinib has a complete clear of metastasis in the lung. Therefore, we start thinking that the EGFR play a very important role in the progression of IBC. And we create this clinical trial that is with a panitumumab plus chemotherapy, nab-paclitaxel, carboplatinum, followed by FEC. And this is a total of the treatment. And we just presented this in ASCO. And we have a remarkable response. We have a 33% pathologic complete response. And this was something very striking, something that we have not seen very well or many often with any other regimens. So panitumumab is a drug is an anti-EGFR, a pan-EGFR inhibitor using in colon cancer patients. This was a phase 1, phase 2. We have a run-in phase. So these patients were exposure 1 week with the anti-EGFR and then continuation with the chemotherapy and with nab-paclitaxel and carboplatinum, and then the anthracycline-based chemotherapy. So this was a small number of patients, 25. A majority of the patients were white, and there has 10 patients were triple negative, 15 patients ER positive. All these patients were HER2 negative, of course. And the 33% of pathologic complete response, there was no association between the tumor subtype, and and also was very important to keep in mind that the toxicity of this patient, toxicity, rash, skin toxicity, and fatigue was perhaps one of the most common toxicities. Nowadays, we are in conversation to open a new clinical trial with something more potent EGFR inhibitor, that is MM151, and this is this drug coming from Merrimack. Merrimack is perhaps one of the Google or one of the Apple biotech companies, are very innovative. They have an enormous amount of drugs, and the majority of this drug has multiple targets. So MM151 is a combination of 3 IgG antibodies that they are associated with the EGFR. So they have a ligand antagonism, they have a receptor downregulation, and also has a very important immune effect. This drug has been presented by Charlie Liu recently from University of Colorado, and have even with tumors with a different expression of EGFR, like a lung, colorectal, and a head and neck, they have an enormous response. So we will try to combine this drug, M151, with our backbone of chemotherapy, very similar like we did with the panitumumab, and we are expecting to have a very good results. In summary, this is my last slide. I think this is a great opportunity to treat this disease with our neoadjuvant chemotherapy models. This is an area where we can apply genomic, genetics, proteomics, multiple modifiers, and minimal residual disease markers. And this was the Morgan Welch inflammatory breast cancer at Anderson, and we just create this in Atlanta in May of this year. And these are my last slide, the conclusions. All the diagnosis of IBC require a multidisciplinary treatment. If you don't have a surgeon or radiation oncologist or plastic surgeon, you should refer this patient to one of these centers. Ideally, all of these patients should be treated with clinical trials. This is an orphan disease. This is a disease very different to the rest. And in terms of the research, we need to define the molecular characteristics of IBC. And finally, we need to have a more xenograph model able to dissect the metastatic process, and will help for a breast cancer patient. Thank you for your attention.